Infectious diseases, preventive medicine and clinical conferences concerning Species 3, 2024-2025, diseases of large ruminants, malignant catarrhal fever of large ruminants, bovine pneumonia with syncytial virus, 3-day fever, 3-day sickness, gangrenous coryza, CG, is a serious, often fatal disease that affects many species of artiodactyls, ungulates with an even number of toes on each foot, including cattle, bison, deer, moose, exotic ruminants, and pigs. At least 10 CG viruses have been identified, including 2 well-known in sheep and wildlife. 6 of these viruses have been associated with the disease, while the others have to date only been found in asymptomatic carriers. Each of the viruses is very well adapted to its usual host and does not normally cause disease in this species, but can cause fatal infections if transmitted to susceptible animals. Gangrenous coryza is present in many countries around the world. Sheep-associated GC is the predominant form of the disease outside of Africa. It is a particular problem in species such as farmed bison, deer and barley beef, although it sometimes affects relatively resistant hosts such as pigs and European breeds of cattle. Wildebeest-associated CG is an important disease in cattle in Africa, while zoos can be affected by either form, as well as less common viruses found in exotic ruminants. Controlling gangrenous coryza is difficult because infections are widespread and asymptomatic in reservoir species, and the incubation period can be long in susceptible animals. The only reliable control methods are to separate susceptible species from carrier species or to rear virus-free reservoir hosts. Etiology: gangrenous coryza is caused by viruses of the macavirus genus of the Herpesviridae family, Gamma herpesvirinae subfamily. There are 2 major groups of CG viruses. The alcelophenii/hypotrageny group includes alcelophin herpesvirus 1, AL-HV1, AL-HV2, hypotragen herpesvirus 1, HI-HV1, and a virus carried by oryxes, MCFV oryx, for malignant catarrhal fever virus in oryx. The caprinae group includes ovine herpesvirus 2, of HV2, caprine herpesvirus 2, CPHV2, white-tailed deer CG virus, MCFV-WTD, and viruses carried by following asymptomatic species, ibex, MCF ibex, muskox, MCF muskox, and mufflin, MCFV audad. Most CG viruses are named after their reservoir host, but MCFV-WTD has been found in diseased white-tailed deer and its healthy carrier is not known. The 2 important viruses are of HV2, which causes CG associated with sheep, and AL-HV1, which causes the wildebeest-associated form. CPHV2, MCFV-WTD, MCFV-ibex and AL-HV2 are also pathogenic. No diseases have yet been associated with MCFV muskox, MCFV oryx, or MCFV audad, which are carried by muskox, Ovibos moscatus, gemsbok, South African oryx, Oryx gazella, and Barbary sheep, Ammotrichus lervia. However, it is likely that these viruses can also cause CG in some animal species. HI-HV1, which was found in asymptomatic roan antelope, Hippotrichus equinus, appears very similar, if not identical, to MCFV oryx. Zoonotic potential: there is no evidence that CG viruses can infect humans. Geographical distribution: CG viruses are found throughout the world, but they only cause disease when transmitted from a carrier species to a susceptible host. AL-HV1-associated disease is primarily seen in sub-Saharan Africa, where wildebeests are found. This virus is believed to be the most important CG virus in parts of Africa, although of HV2-associated disease is also present. Of HV2 is the main agent of GC in domestic animals outside of Africa. Sheep-associated CG is common in barley cattle in Indonesia. However, cases in cattle are rare in countries where Bos taurus and Bos indicus are the predominant species. Of HV2 is of great concern in countries where bison and deer are farmed, because these species are very sensitive to it. At one time, infections in pigs were mainly reported in Norway, but sick pigs have now been found in other European countries and North America and are expected to occur elsewhere. OVHV2 is believed to be the main cause of GC in ruminants in zoos and wildlife parks. Several other CG viruses, including LHV1, MCFV ibex, and others carried by exotic species, can also cause illness in these locations. Transmission. CG viruses, like other herpes viruses, produce latent infections that persist throughout life. In wildebeest, LHV1 occurs in cellular and acellular form. Animals excrete the acellular form in their nasal and eye secretions for a short time after being infected. Then, the virus mainly manifests itself in the cell-associated form, which is rarely transmitted to other animals. However, the acellular form of the virus can be isolated from the nasal secretions of certain animals that are stressed or have received corticosteroids. LHV1 is spread primarily by wildebeest calves, which can be infected in utero, through direct contact with other wildebeest, or through aerosols during close contact. Viral shedding is most intense during the first 3 to 4 months of life, and most calves are believed to be infected through their cohorts. Contamination of pastures can also contribute to transmission. Neutralizing antibodies usually develop at around 3 months of age, and shedding decreases after this time. After 6 months of age, wildebeest excrete little virus, except when they are stressed or during parturition. Transmission. Most cases of wildebeest-associated CG are observed when susceptible animals are exposed to parturient female wildebeest or young calves. This usually occurs after close contact, although transmission has been reported in animals separated by at least 100 meters. Inhalation is thought to be the primary means of transmission for all CG viruses, although ingestion also appears possible. The cellular form of LHV1 is very fragile, and its infectious capacity disappears after 3 days in the environment. On the other hand, the acellular virus can survive more than 14 days in a humid environment. CG viruses are rapidly inactivated by sunlight. Like LHV1, OVHV2 appears to be excreted primarily in nasal and ocular secretions. The virus is shed intermittently for short periods, usually lasting less than 24 hours. Although sheep of all ages can transmit OVHV2, one study showed that lambs aged 6 to 9 months had the highest concentrations of virus and the most frequent shedding. In naturally infected flocks, most lambs appear to be infected after 2 months of age. Circumstantial data, antibodies against CG viruses discovered in a study on notobiotic sheep free of specific pathogens, and the discovery, in colostrum and milk, of virus-infected cells seem to indicate the possibility of vertical transmission of OVHV2. However, this type of transmission seems rare. Virus DNA has also been reported in the semen of rams. The number of CG cases associated with sheep increases during the spring lambing season. Susceptible animals usually become infected with OVHV2 when in close contact with sheep, but cases have been reported when sheep and cattle were separated by 70 meters. An outbreak in bison occurred in herds that were up to 5 kilometers from a lamb feedlot. Transmission of CPHV2 in goats appears to resemble that of OVHV2 in sheep. In an infected goat herd, at 10 months of age, 94% of the goats were infected. In this herd, CPHV2 DNA was detected for the first time in 3-month-old kids. At 7 months, almost 50% were seroconverted, and at 9 months, more than 80% were. There were no signs of infection at birth, and none of the goats removed from the herd at 1 week of age were infected. Adult animals were also easily infected when exposed to a herd infected with CPHV2. Ruminants that develop gangrenous coryza are usually dead-end hosts. A few cases of animal-to-animal transmission have been suspected in cattle, pigs, and deer infected with OVHV2, although there is no indication that this is possible. In pigs, large amounts of OVHV2 DNA have been found in the semen of asymptomatic wild boars as well as in the nasal mucosa and skin of diseased animals. The observations also reveal that certain non-reservoir hosts could transmit CG viruses to their offspring. A recent study suggests that there is no horizontal transmission in bison. Subclinical infections with HV2 have been reported in some cul-de-sac hosts, including cattle, bison, deer, and pigs. Recrudescence could be possible in these animals, although it appears rare, even in stressed animals. Incubation. The incubation period varies depending on the virus, host and other factors, and is not very well understood. Cattle became ill 11 to 34 days after inoculation with ALVH1 and 11 to 73 days after administration of blood from sick cattle infected with HV2. In bison exposed to sheep, the incubation period is often a month or more, with peak losses reported between 40 and 70 days after exposure. The incubation period lasted from 2 to 6 weeks in pregnant bongos with ibex-associated CG in a zoo, and from 21 to 40 days in 1-week-old piglets inoculated intranasally with HV2. Latent infections and resurgence could also be possible. Epidemiological data indicate that some cattle may have clinical infection for more than 20 months before disease manifests. In clinically infected bison, clinical cases tended to appear 3 to 14 days after the animals experienced handling stress. Clinical signs. Gangrenous coryza can cause different clinical signs depending on the species and their susceptibility to the virus. Subclinical infections are common in reservoir hosts. Asymptomatic infections have also been reported in some dead-end hosts such as cattle, bison, deer, and pigs. In clinical cases, almost any organ can be affected, although the gastrointestinal tract, eyes and central nervous system are often involved in domestic ruminants. Per acute disease, which tends to occur in highly susceptible species, progresses very quickly, with few clinical signs before death. In some animals, death may be preceded by 12 to 24 hours of profound depression, weakness, diarrhea or dysentery. Clinical signs are more apparent in animals that survive longer, such as cattle, which may be ill for a week or more before dying. In addition to high fever and loss of appetite, cattle often exhibit bilateral corneal opacity, which begins at the corneal limbus and progresses inward. Initially, serous discharge from the eyes and nose is common, later it becomes purulent mucosa. The muzzle and nostrils are usually crusted, and dyspnea, salivation, and mouth breathing may be observed. The oral mucosa is often with hyperemia, may contain multifocal or diffuse areas of necrosis. Erosions can be seen at the tips of the oral papillae. In cattle, superficial lymph nodes are often enlarged. The skin is sometimes erythematous or ulcerated, and hardened scabs may accumulate, particularly on the perineum, udder and teats. In some animals, the covering of the horns and hooves may become loose and fall off. Joints may be swollen, and milk production often decreases. Diarrhea, hemorrhagic gastroenteritis or hematuria may also be seen, although these signs are less common than in bison and deer. Occasionally, animals develop neurological signs, especially in the terminal stages. Even if many or most animals die, chronic infection or recovery is possible. Cattle that survive may have persistent eye damage. Skin lesions have been reported in some cattle without other clinical signs and may resolve spontaneously. Clinical signs are similar in other species, but some aspects of them often vary. For example, corneal opacity is not always present in water buffaloes with CG, but mild to moderate conjunctivitis appears common. Bison often die quickly, without developing purulent rhinitis or keratoconjunctivitis. In bison herds, symptoms are subtle, but in some cases the following signs may be observed: anorexia, depression, corneal opacity, tearing, slight serous nasal and eye discharge, coughing, salivation, diarrhea and neurological signs. In the later stages of the disease, bison often present with an edematous band in the corneal limbus, a lesion that is difficult to recognize in living animals. Until they are close to death, bison seem to try to camouflage their clinical signs. Inhalation pneumonia is common in the later stages of the disease, and some sick bison may be attacked by their conspecifics, which can result in trauma. Lying animals usually die within a few hours. In deer, gangrenous coryza is often acute, with death occurring within a few days, without characteristic signs necessarily being observed. In more resistant species, symptoms more typical of CG are reported, including deep depression, loss of vitality, rough coat, nasal discharge, corneal opacity, transient loose stools, hemorrhagic diarrhea and bloody urine. Some animals survive up to 3 weeks after the onset of the disease. Skin lesions have been found to be the primary cause of pain in deer infected with CPHV2. In white-tailed deer infected with this virus, the main lesions were generalized alopecia, thickening, crusting, hyperkeratosis and focal ulceration of the skin, weight loss, and vision problems. In some animals, the hoof walls became detached. Neurological signs, including abnormal behavior, apathy and incoordination, have been reported in wild moose and deer. Most of HV2 infections reported in pigs have been acute or peracute, with high fever and dyspnea the most common signs. Subclinical infections and chronic cases lasting several weeks have also been reported. In some outbreaks, pigs developed crusted rhinitis or foul-smelling nasal discharge, erosions on the nasal and oral mucosa, corneal edema, or uveitis. Other reported signs included hematuria, reproductive losses, abortions, stillbirths and smaller than normal litters, red spots on the skin and neurological signs. In some outbreaks, only pregnant females were affected. 1-week-old experimentally infected piglets showed fever, apathy, anorexia, adipsia, transient rash and convulsions, but there were no signs of runny nose or eyes, corneal opacity or diarrhea. However, these piglets could have been euthanized before the appearance of certain clinical signs. Although of HV2 infections are often fatal in pigs, some animals have recovered. Gangrenous coryza is characterized by inflammation and epithelial necrosis, with proliferation of lymphocytes, infiltration of non-lymphoid tissues by lymphoid cells, and vasculitis. The extent of the lesions varies depending on the severity and progression of the disease. In cattle that die suddenly, there may be few abnormalities other than hemorrhagic enterocolitis. In less acute cases, the carcass may be dehydrated, emaciated or normal. Bilateral diffuse or focal corneal opacity is common, and corneal ulcers are sometimes present. The muzzle is often raw and crusted due to serous, purulent or purulent mucosal discharge from the nose. Hyperemia, edema and small focal erosions or ulcers may be seen on the nasal mucosa. Some animals may have dermatitis and skin ulcers. Although their degree of involvement varies, lymph nodes are usually enlarged in cattle. When cut, they may be firm and white, hemorrhagic or necrotic. Petechiae or ecchymosis may be seen on various serous surfaces. Prominent white foci 1 to 5 mm in diameter may be seen in some tissues, particularly the kidneys. These nodules are sometimes surrounded by a small hemorrhagic area. The gastrointestinal tract may show erosions and hemorrhages. In severe cases, intestinal contents may be hemorrhagic. However, lesions in the gastrointestinal tract can be difficult to recognize, especially if the carcass is autolyzed. The upper respiratory tract often presents with exudates and catarrhal erosions, and a diphtheria membrane may be present. Ecchymotic hemorrhages, hyperemia, and edema are common in the bladder mucosa. In more chronic cases, the small arteries in many organs may be very prominent and tortuous, with thickened walls. Similar lesions have been reported in other species, but some specific differences have been noted. For example, in bison, vasculitis tends to be milder than in cattle, and lymph nodes are less likely to be enlarged, but hemorrhagic cystitis and hemorrhagic colitis are more common. In bison that die without showing many clinical signs, the lesions observed at necropsy may be advanced. In 3 periparturient female bongos, signs of CG included necrotizing cholangiohepatitis, necrotizing neutrophilic myocarditis as well as other lesions more characteristic of CG. Severe perirenal hemorrhages and multiple renal infarctions were observed in Stone's sheep thought to have CG, as well as petechial hemorrhages in multiple tissues and serosanguinous fibrinoid effusions in some body cavities. Cattle, snout. Many superficial erosions are filled with dried nasal exudate. Cattle, snout. The muzzle is hyperemic, covered with several layers of adherent mucopurulent exudate and numerous shallow erosions. Cattle, snout. Diffuse superficial necrosis of the muzzle. Cattle, oral mucosa. Gingival hyperemia and focal erosion. Bovine, hard palate. Several coalescent erosions of the mucosa. Cattle, skin. Numerous raised plaques, multifocal dermatitis. Bovine, head, sagittal section. Mucoid exudate multifocally covering the nasal and pharyngeal mucosa. Bovine, nasal turbinate. Presence of a small amount of mucoid exudate. Cattle, prescapular lymph nodes, moderately, left, to significantly enlarged, right, due to FCM. Bovine, prescapular lymph node. Hemorrhagic and necrotic, foci in the cortex, and the medulla is edematous. Cattle, omasum. The layers of the omasum contain several pale foci of necrosis. On the right we notice several ulcers. Bovine, cecum and ileum. Small scattered foci of hemorrhage and erosion of the mucous membranes. Cattle, spiral colon. Several mucosal hemorrhages. Bovine, colon. Severe longitudinal linear congestion of the mucosa. Cattle, kidney. Multiple pale foci in the cortex. These are foci of interstitial nephritis. Cattle, urinary bladder. The mucosal surface contains several small erosions and a large bleeding ulcer. Diagnostic. Sick animals. It is often the microscopic lesions in the tissues taken at necropsy that give rise to suspicion of gangrenous coryza. As some GC viruses cannot be isolated from infected animals, PCR assays are often the method of choice to confirm infection. Lymphoid tissues such as the spleen and lymph nodes are preferred for these tests, but others can also be used. Most PCR tests detect AL-HV1 and/or of HV2, but some can also detect other CG viruses.
Epidemiological information, e.g., contact with sheep, but not wildebeest, should guide the choice of PCR assays.
Infections with viruses of the Alcelaphini/Hippotrageny group, such as AL-HV1, can also be diagnosed by isolation of the virus from the blood of live animals or from lymph nodes, spleen, and other affected tissues collected at the necropsy. AL-HV1 is rapidly inactivated in dead animals, and samples should be collected as soon as possible. The most useful samples are collected immediately. Host cells must be maintained after sample collection because the virus cannot be isolated from dead cells. AL-HV1 can be isolated from bovine thyroid cells or other sensitive cell lines, and it can be detected by immunofluorescence or immunohistochemistry. Of HV2 and CpHV2 cannot be isolated by cell culture. Diagnostics. Sick animals. Serological tests for the detection of CG viruses will include viral neutralization, immunoblotting, enzyme-linked immunosorbent assays, ELISA, and immunofluorescence or immunoperoxidase tests. All of these tests are based on Alcelaphine herpes virus antigens, mainly AL-HV1, which can be cultured in cells in vitro.
Although they can detect antibodies against other CG viruses, e.g., of HV2 and CpHV2, these tests cannot distinguish reactions to different viruses.
Most serological tests can be used in sick animals, however, the viral neutralization test cannot be used, since these animals do not usually produce neutralizing antibodies.
Cross-reactions with other herpes viruses, e.g., bovine herpes virus 4, are possible, particularly in tests that use polyclonal antibodies.
Most sick cattle and bison are seropositive. Since healthy animals may also have antibodies to CG viruses, serology should be used in conjunction with histopathology and clinical observations. It is difficult to corroborate a diagnosis of CG in a virus reservoir host. Critical components include histopathology and elimination of other possible causes of disease. Reservoir hosts. PCR can be used to document the absence of infection in certain reservoir hosts, for example, when producing of HV2-free sheep. To do this, very sensitive PCR tests must be used. The peripheral blood leukocytes of most infected sheep contain enough of HV2 DNA that it can be detected by PCR, but this is not the case in infected oryx or black wildebeest. Furthermore, in 85% of goats which have antibodies against CpHV2, the PCR is positive. Serological tests can also be used to identify reservoir hosts. Seroconversion can take more than 4 weeks in animals that have received a low dose of virus. Maternal antibodies can be a problem in lambs younger than 4 months. All serological tests, including viral neutralization, ENV, can be used in wildebeest. ENV is not useful in sheep and goats infected with HV2, CpHV or related viruses, because in these animals the titers of AL-HV1 neutralizing antibodies are low or absent. Cell-free viruses can be found in wildebeest calves in nasal secretions for short periods after infection. The virus can also be isolated from peripheral blood leukocytes during these periods.
However, such isolation is more difficult in older wildebeest, unless they are immunocompromised, e.g., due to stress or drug treatment.
Cell-associated AL-HV1 can be isolated from tissue cultures from wildebeest, sensitive subclinical infected species. In subclinical infected bison and cattle, HV2 DNA concentrations are very low, which can make the virus difficult to detect by PCR. However, such infections are not expected to be clinically significant, since these animals are considered dead-end hosts of the virus. Regarding surveillance activities, animals with subclinical infection can be detected more easily by a serological test than by a PCR test. Treatment. There is no specific antiviral treatment. Antibiotic therapy to combat association infection and supportive care can sometimes help, but a large number of affected animals will die. Combat, fight. Veterinarians who discover or suspect gangrenous coryza should follow national or local disease reporting guidelines. In the United States, gangrenous coryza is a reportable disease in many states. State authorities should be consulted for more information regarding this disease. Prevention. To prevent gangrenous coryza, susceptible animals can be separated from sheep, goats, wildebeest and other suspected reservoir hosts. Wildebeest appear to transmit AL-HV1 easily and should always be separated from cattle. Susceptible animals should not graze on pastures recently grazed by these animals, particularly around the time when female wildebeest are giving birth. To prevent sheep-associated GC, sheep must be separated from bison, certain deer, and other species highly susceptible to the disease. Although this form of CG can also affect European breeds of cattle, cases are rare and separation of cattle and sheep is not always necessary. Some sheep flocks have been associated with recurrent transmission to cattle over years. Separation or selective culling of such herds should then be considered. Prevention. In zoos and wildlife parks, the fight is complicated by the number of potentially susceptible animal species and the number of carriers of CG viruses, which are often poorly characterized. In addition to the HV2 and AL-HV1 viruses, there have been at least 2 incidents involving transmission from a Nubian ibex to a bongo.
Increased receptivity, e.g., during gestation, or increased virus shedding, e.g., recently acquired animals stressed by their new environment, could be factors in some outbreaks.
The minimum separation distance is not known. Although most infections occur when the carrier host and susceptible animals are in close contact, transmission of AL-HV1 has been reported in animals that were separated by at least 100 meters. Transmission of HV2 was reported in cattle that were 70 meters from a lamb farm. The disease has also been reported in bison herds up to 5 kilometers from a lamb feedlot. Separation by greater distances would likely be necessary for a very susceptible host and high virus concentration. Transmission by fomites must also be avoided, particularly when the species is very susceptible. In some cases, the production of virus-free hosts may also be considered. of HV2-free domestic sheep and bighorn sheep were produced by early weaning, isolation and testing for the virus. To produce CpHV2-free goats, goats were isolated from the infected herd at 7 to 10 days of age. An outbreak in a zoo was controlled by the removal of infected sheep species, followed by the reintroduction of virus-free bighorn sheep from the infected herd. There is no commercial vaccine against these viruses. During outbreaks, susceptible animals should be separated immediately from the suspected source of the virus to prevent further cases. Despite uncertainty about the possibility of horizontal transmission in some species, most accidental hosts are epidemiological dead ends. Current consensus is that it is not necessary to slaughter or separate sick animals from susceptible animals. Because the incubation period can be very long, cases may continue to occur for months, even after the animals have been separated from the source of the virus. Reducing stress may help prevent disease in subclinically affected or mildly affected animals. Bovine respiratory syncytial viruses, SBVR, and human viruses, SHVR, are important and common pathogens of respiratory diseases. They induce a respiratory pathology, which results in different clinical forms ranging from influenza syndrome to acute respiratory distress syndrome. In the EU and France, the seroprevalence of VRSB is 60%. This virus is co-responsible for more than 50% of respiratory disorders in cattle under 12 months of age. It is detected alone in 30% of cases, which places it at the top of the respiratory pathogens, Kimmon, 1988. The mortality rate in this age group varies between 2 and 5%, but can reach 30%. The VRSB study therefore has a double interest. Direct by its medical aspect in cattle breeding. Indirect by the economic losses caused for breeders. Vaccination currently represents the only means of combating VRSB infection, which has been practiced for more than 20 years in the EU using attenuated and inactivated vaccines. Generally speaking, vaccines protect animals clinically, and have very probably allowed and limited viral circulation. However, they do not prevent reinfection of the calf with another strain. In addition, vaccination faces various obstacles, namely immunization in the presence of maternal antibodies, the possibility of an immunopathological reaction induced by vaccination, and the antigenic variability of the virus. VRSB is an RNA virus of negative polarity, which belongs to the order Mononegavirales. The order Mononegavirales is subdivided into 4 families differentiated according to morphological and structural criteria. Family Rhabdoviridae, to which the vesicular stomatitis virus and the rabies virus. Family Filoviridae, whose unique genus Filovirus includes the Ebola virus. Family Bornaviridae with Borna disease virus and Family Paramyxoviridae, to which VRSB belongs, divided into 2 subfamilies. Paramyxovirinae pneumovirinae. The pneumovirinae subfamily includes 2 genera including the pneumovirus genus, Photo, to which VRSH, VRSB, mouse pneumovirus and caprine respiratory syncytial viruses, VRSC, and ovine respiratory syncytial viruses, VRSO, belong. Cross-infections between sheep and cattle have been observed, but VRSB is not a zoonotic agent, no demonstration of passage of the human virus to cattle and vice versa. VRSB is a negative sense, pleomorphic, enveloped, single-stranded, non-segmented RNA virus whose genome is made up of around 15 kilobases. The genes code for 11 proteins. 2 non-structural proteins, NS1 and NS2. 3 proteins associated with the nucleocapsid, a nucleoprotein, a phosphoprotein and a polymerase L. 3 matrix proteins. 3 envelope proteins, SH, small hydrophobic, F, fusion, G, glycoprotein which exists in a form anchored to the envelope and in a free form. Epidemiology. The breeding system, the incidence of seroconversion is very high, in the USA for example, following batching, feedlots. Age, the lowest frequency of seropositive animals is found in calves less than 6 months old, reaching its maximum in adult cattle, 95 to 100% seroprevalence. The seasonality of infections is centered on winter, but it can spill over into autumn and spring. It is explained by climatic data. The great lability of the virus in the external environment in the event of heat and low humidity. The seasonality of births. The place of VRSB in respiratory infections of cattle. VRSB is at the forefront of viral and bacterial infections in a context of acute respiratory disorders of epidemic evolution in calves aged from 15 days to 4 months, evidenced alone or associated in a third of cases. Prevalence of pathogens responsible for respiratory infections. Case control studies have concluded that there is a strong causal link between RSV infection and clinical disorders. Results subsequently confirmed by experimental infections. Epidemiology. The infection is limited to the respiratory system, without any dissemination in the body. Only the nasal cavities, trachea and lung are likely to be infected. VRSB is very strongly associated with cells. Very little virus is found in the extracellular position. This explains the need to recover as many cells as possible from the respiratory system during diagnostic tests. The main virulent materials are respiratory secretions and in particular the discharge. Transmission is essentially direct by aerosol or contact. However, possible indirect contamination has been demonstrated in hospital contexts for human RSV. However, it is limited in time due to the great lability of the virus in the external environment. The virus is introduced into livestock farming following the purchase of animals, or by human vectors, notably soiled hands, or by restraining instruments such as fly pliers. VRSB is circulating in farms with a recurrence of infections whose origin still raises questions. First hypothesis: existence of chronic carriage. It has not been demonstrated, despite the discovery of some remains of virus in B lymphocytes more than 2 months after infection. Second hypothesis: circulation throughout the year. Recurrent episodes in closed herds without introduction were observed with significant nucleotide divergences between the successively isolated viral strains. The Danish authors then concluded that there was a high probability of new introductions. In reality, and given the existence of quasi-species for this virus, and despite the nucleotide divergence, we cannot exclude internal circulation within the herd, without reintroduction. Seasonality of infection and viral persistence. In cattle, the seasonality of infection is very important. Indeed, in temperate regions the number of cases of VRSB peaks in autumn and winter. This seasonality would be due to climatic changes and in particular to drops in temperature. Although the virus only seems to circulate during the rest of the year at a very low level, reinfections are possible. The absence of VRSB disease during the summer period raises the question of viral persistence. In a region already infected with this virus, the disease becomes endemic and can affect the same herds every year. Given the fragility of the virus, the reappearance of respiratory episodes in the same farms over several consecutive years suggests a reintroduction of the virus and/or its maintenance within the animal reservoir. Given that respiratory episodes with VRSB can reappear within the same herds every winter without the introduction of new animals, it would seem that either the virus circulates quietly and permanently in clinically infected animals, or it persists in the strict sense in the infected animal. The modes of viral persistence are not yet fully elucidated. However, chronic infection is well known for other viruses of the Paramyxoviridae family. Randall, 1991. In addition, some experimental elements support the hypothesis of persistence.
In vitro, the virus is capable of infecting cells persistently while losing its cytopathic power, and studies have shown that VRSB could be detected up to 71 days post-inoculation, PI, in B lymphocytes of tracheobronchial and mediastinal lymph nodes.
However, persistence of the virus in animals associated with a phenomenon of re-excretion has not been demonstrated. Clinical signs and lesions. Incubation of the disease is 2 to 8 days according to observations during natural contamination. In 21 to 47% of cases, the natural infection is clinical. Otherwise, clinical infection results in a febrile syndrome and respiratory symptoms. General symptoms: high hypothermia, moderate decline in general condition, anorexia, are often transient, 1 to 3 days, and noticeable at the beginning of infection, but can worsen into severe depression and coma. It is mainly the respiratory signs which predominate. Mucus to mucopurulent nasal discharge and cough persist for up to 10 to 20 days in half of cases. Polypnea, increased auscultation sounds, very audible expiration, added noises, wheezing, crackles, and abdominal dyspnea with subcutaneous emphysema can last 6 to 10 days. Damage to the upper respiratory system, resulting in clinical signs of rhinotracheitis. The animal presents with inspiratory difficulty, coughing and wheezing. The course of the disease is generally benign, flu-like. An attack on the lower respiratory system resulting in bronchiolitis or bronchopneumonia. The progression of the disease can also worsen suddenly. In certain very severe cases, an exacerbation of bronchiolitis occurs, referred to as acute respiratory distress syndrome. We note the presence of extremely severe dyspnea with the head held low on a tense neck, open mouth, expiratory complaints and abdominal breathing, indicative of expiratory difficulty caused by lower airway obstruction and emphysema pulmonary. The animal can no longer move or eat and makes enormous efforts to breathe. It is possible to detect pulmonary edema and emphysema upon auscultation. This emphysema can even spread to the subcutaneous or abdominal connective tissue via the lymphatic route. The observation of these clinical signs is modulated by numerous factors such as the anatomical, physiological and immune particularities of the young person compared to the adult, the virulence of the VRSB viral strain, congenital or acquired immune deficiencies as well as bacterial superinfections. Two pulmonary regions can be differentiated in terms of the lesions that can be observed macroscopically when affected by VRSB, the cranial ventral region and the caudal dorsal region. In the cranial ventral region, the preferred area of attack in airborne pulmonary disease, we find lesions characteristic of bronchointerstitial pneumonia. The parenchyma is generally congested, brick red to wine color, with moderate induration. On the cut, we can note the presence of mucopus in the bronchi. On histological examination, this interstitial pneumonia is mainly characterized, during rapid progression, by lesions of necrotizing bronchitis and bronchiolitis with the presence of desquamated epithelial cells in the lumens, often associated with neutrophils and macrophages, obstructing the lumen. The presence of syncytial cells is frequently noted in the bronchial and alveolar lumens, cells that can also be found in the nasal and tracheal mucous membranes. False fibrin membranes lining the alveolar walls are also frequently encountered. In the case of longer courses, epithelial hyperplasia with bronchiolitis obliterans can be observed. In the caudal dorsal region, the dominant macroscopic lesion is generally interlobular and subpleural emphysema, sometimes even alveolar, sometimes associated with slight induration of the parenchyma. However, the absence of emphysema does not exclude involvement by VRSB. On histological examination, the lesions of necrotizing bronchiolitis and the presence of syncytia are more discrete. On the other hand, we find lesions of alveolar and interlobular emphysema, and the frequent presence of false fibrinous membranes, probably responsible for the slight induration that we observe macroscopically. The lesions can also follow the pathways of lymphatic drainage. Thus, we sometimes observe marked mediastinal emphysema, which can extend to the subcutaneous plane, in the shoulder and neck region, as well as hypertrophy of the tracheobronchial and mediastinal lymph nodes. Diagnosis of VRSB infection. On live animal. The epidemiological clinical elements are of low reliability, in a context of an epidemic of respiratory disorders with variable clinical signs, none with acute respiratory distress. The suspicion of RSV is legitimate but not certain. Virus detection using analytical techniques. Detection of antigens by capture ELISA or by immunochromatographic method. Quantitative PCR, interpret with caution when using a live attenuated vaccine intranasally, which may lead to the detection of vaccine virus on a deep nasal swab up to 14 days after administration. Search for the virus by isolation. This is theoretically possible but very difficult in practice due to the lability of the virus in the external environment. The best respiratory samples, transtracheal aspiration and bronchoalveolar wash, then deep nasal swabbing. A recent study conducted in the USA showed that when detected by quantitative PCR, the deepest samples, ATT or LBA, give a greater frequency of positive results than ENP. We must therefore favor ATT or LBA. Retrospective diagnosis by serology, still possible and interesting, despite limitations, particularly in calves less than 3 months old, linked to interference with AC of colostral origin. The frequency of seroprevalence in adult herds being around 90%, calves which have correctly drunk their colostrum will carry passive antibodies which will block the production of active antibodies, protective IgG1, because it is neutralizing, they reduce clinical expression. As IgG1 does not appear, there is no possibility of confirming exposure of calves to RSV, especially since the calf is young with a high stock of colostral antibodies. Diagnosis of VRSB infection. The frequency of seroprevalence in adult herds being around 90%, calves which have correctly drunk their colostrum will carry passive antibodies which will block the production of active antibodies, protective IgG1, because it is neutralizing, they reduce clinical expression. Since IgG1 does not appear, there is no possibility of confirming exposure of calves to RSV, especially since the calf is young with a high stock of colostral antibodies. Lesions. Quite suggestive are those of acute bronchointerstitial pneumonia. It is possible to complete the observation by testing for viral AG or by quantitative PCR. The signs are moderate pulmonary induration, mucopus in the bronchi. They must be distinguished from chronic bronchitis. In this case, the induration is also moderate, but the major difference concerns the bronchial lesions with dilated bronchi, containing often pasty/creamy pus. Chronic bronchitis with bronchial abscesses is characteristic of a chronic course, and caused by bacterial infection secondary to a possible initiating viral infection. The direct action of VRSB is through colonization of the respiratory system, inflammation and partial escape from the defense mechanisms of the respiratory system. Cellular necrosis of the bronchial and alveolar epithelium is observed with a reduction in mucociliary purification mechanisms, accompanied by infection of alveolar macrophages. Non-structural proteins reduce the production of INF1. HS decreases the innate response. Soluble protein G reduces the antiviral effects of the surfactant and acts as a decoy for neutralizing antibodies. At the same time, the virus has developed mechanisms explaining lesions and symptoms. The F protein plays a role as a virokine by causing bronchoconstriction added to the constrictions mediated by the inflammatory reaction. The indirect immunoinduced action of VRSB promotes viral or bacterial, Pasteurella, co-infections following the disturbances it induces in the immune response. It is considered that the lesser severity in very young calves, compared to calves of a few weeks to several months, is linked to the lower production of TNF-alpha, pathogenesis. Normal cytolytic activity, the cytotoxic LT will play their curative role. Bronchial hyperreactivity and inflammation due to the action of VRSB on the CD4 type 2 response, explaining part of the lesions and symptoms, acute respiratory distress syndrome. Microscopic inflammatory and necrotic lesions of the epithelia, bronchitis and false membranes lining the interior of the alveoli. They result from phenomena of exudation and necrosis of pneumocytes. Bronchointerstitial pneumonia is observed with frequent emphysema in the caudal lobes but not specific. Acute bronchointerstitial pneumonia and mucopus. Chronic bronchitis, bronchiectasis with creamy pus. Diagnosis of VRSB infection. A diagnosis based solely on symptomatology is impossible, because respiratory disorders are not very specific. Only a laboratory diagnosis can confirm a suspicion of VRSB infection in a herd. The results obtained during laboratory examinations must be interpreted taking into account several parameters. The age of the animal, the peak clinical incidence occurs in animals less than 6 months old, and serum antibodies of maternal origin, still present at this age, can hinder the definitive diagnosis. The type and quality of the sample. VRSP is very strongly linked to cells, so a sample containing few cells is of little use for virological analysis. The method of preserving the samples. This virus is very weak and fragile. Storage under negative cold is preferable to room temperature. The sensitivity of the technique used. The delays between the start of clinical signs and taking the samples, between death and taking the samples, and between taking the samples and starting the analyses. The virus is very fragile in the external environment and replication viral is short-lived in the respiratory tract. The techniques are RT-PCR, RNA, or detection of viral antigens in live or dead animals, as these are easy to implement techniques. Despite everything, they do not always provide a satisfactory answer. Living animals. Serology, indirect research. Serological diagnosis requires at least 2 samples in order to detect seroconversion or a significant increase in the titer of antibodies directed against VRSP. The first blood sample should be taken during the acute phase of the infection and the second between 2 and 3 weeks after the first sample. Among the different techniques available to demonstrate these serum antibodies, indirect immunofluorescence, serum neutralization or complement fixation, the most used remains the ELISA technique. In addition to its sensitivity and specificity, it allows results to be obtained quickly and easily. Given the high seroprevalence of the virus in adult cattle, the frequency of calves carrying anti-VRSP antibodies of colostral origin is very high and hampers serological diagnosis. Passive immunity partially or completely blocks the synthesis of IgG, but not that of IgM, following an infection. Conventional ELISA tests only detecting IgG are therefore often of limited use in the definitive diagnosis of VRSP in young animals. Different sampling techniques are used to detect VRSP, namely nasal swabbing, NS, transtracheal aspiration, ATT, and bronchoalveolar washing, BAW. However, samples from the deep respiratory tract, BAW, seem richer in viruses, which can be explained by the richness of cells in the bowel and by the pulmonary localization of the virus during serious infections. Viral isolation. This is the classic technique, but it is rarely used in routine diagnosis, because the results are uncertain due to the lability of the virus and the difficulties of packaging and preservation in the laboratory. Detection of viral antigens. This is the safest technique in the acute phase of infection. Antigen detection is carried out on samples obtained by NS or BOR. Contamination of nasal secretions by bacteria or fungi does not interfere with antigen detection. The immunofluorescence, IF, technique allows detection of a larger number of positive samples and over a longer period, up to 14 days p.I., on nasal cells and 18 days p.I., on bowel cells, then isolation viral, whatever the respiratory stage where the sample is taken. Enzymatic immune antigen detection techniques have been developed for VRSH with very good specificity and sensitivity compared to viral isolation or IF. Some of these tests have been used for VRSP due to the high antigenic similarities with VRSH. There is now a specific veterinary test, speed-re-SPIV test, BioVito test. The advantage of this field test is that it can be carried out immediately in the clinic. Detection of viral RNA. The technique of reverse transcription, followed by gene amplification, RT-PCR, seems interesting, particularly when amplifying a gene segment that varies little, such as that of the N-nucleoprotein. Storing samples, nasal secretions, at +4 degrees Celsius for 12 hours does not reduce the sensitivity of the RT-PCR method. Dead animal. At autopsy, viral antigens can be detected using RT-PCR techniques, fragment of fresh or frozen lung parenchyma, or immunofluorescence, IF, on sections of fresh or frozen lung. Enzymatic immune techniques can be used on the mucopus present in the bronchi to detect the VRSP antigen. Histological examination has the advantage of visualizing lesions characteristic of VRSP infection, see lesions paragraph. This examination can be supplemented by immune histochemical techniques, immune peroxidase IP, on frozen lung sections or on paraffin sections to demonstrate the presence of viral antigens, as well as the cellular structures hosting these antigens. Samples should preferably be taken from the cranioventral lung lobes, particularly due to the lack of viral antigens in the more caudal regions. Due to the great lability of the virus, the success of the diagnosis is mainly conditioned by the freshness of the sample, vaccination against VRSB and viral evolution. Vaccination. Prevention through vaccination involves obtaining and using effective vaccines. In veterinary medicine, attenuated and inactivated vaccines against VRSB are already on the market. Live vaccines have the advantage of eliciting an immune reaction close to that observed during natural infection, even in the presence of maternal antibodies. The disadvantages of these vaccines can be reverse mutations and the circulation of vaccine strains in the population. Inactivated vaccines are completely incapable of multiplying, both in vitro and in vivo. They are obtained by exposure of the pathogen to a physical agent, heat, or especially currently a chemical agent, formalin, beta-propiolactone, ethylene imine, etc., which leads to a total loss of infectivity without denaturing its immunogenic power. In order to obtain a satisfactory immune response, these vaccines must contain a large mass of antigen and frequently require the presence of adjuvant, two factors which explain their higher production cost than modified live strain vaccines. Generally speaking, live and inactivated vaccines protect animals clinically and they have very probably helped to limit the circulation of the virus. However, they do not prevent reinfection of the calf. In 1999, one of the inactivated vaccines was withdrawn from the market, Vacors, because pharmacovigilance studies showed a frequency considered to be abnormally high of mortality associated with VRSB in previously vaccinated cattle. Southern European countries, such as France, Italy or Spain, have been practicing large-scale vaccination for more than 20 years, while Nordic countries such as Sweden or Denmark have only been practicing vaccination for 1996. In France, according to a marketing study involving 400 breeders with at least 40 adult cattle and representative of French breeding, 16% of dairy cattle, 36% of suckling cattle under 1 year old and 30% are vaccinated. Wool calves. The issue of vaccination against VRSB is based on different criteria. The safety of vaccines, particularly inactivated vaccines. The need to vaccinate at an age when the calf's immune system is immature. The presence of colostral antibodies which interfere with the development of a post-vaccination immune response. The need to induce a strong local immune response. The variability of viral strains compared to different vaccines. 3-day fever is a viral disease caused by an ephemerovirus of the Rhabdoviridae family transmitted by arthropods vectors. It is common in tropical and subtropical zones and particularly affects cattle and domestic buffalo, especially in intensive breeding for dairy production or fattening. It leads to a reduction in milk production, a drop in animal fertility and abortions, hence its economic importance. The disease, generally benign, is expressed in susceptible subjects by a febrile episode of sudden onset, associated with muscular damage with arthritis, stiffness of the limbs, lameness affecting several animals simultaneously with a rapid progression towards recovery. The presence of serofibrinous exudates in the joints is suggestive of the disease. In the absence of pathognomonic signs, clinical diagnosis is often difficult. However, the epidemiological elements, proliferation of arthropod vectors, associated with a short-term fever and the presence of neutrophilia with numerous immature forms make it possible to strongly suspect 3-day fever. In the absence of specific treatment, symptomatic treatment is based on the use of antibiotics and anti-inflammatories. Medical prophylaxis uses live-attenuated virus vaccines, pending the development of recombinant vaccines which have given promising results. Etiology. Conical in shape, the 3-day fever virus is an enveloped virus that has spikes on the surface. With a size of 180 nanometers in length by 73 nanometers in diameter, the nucleocapsid is made up of a single-stranded RNA with negative polarity. The envelope, which is lipoprotein in nature, has fine projections on its surface, spicules. 5 major proteins characterize the virus, 19, namely the envelope glycoprotein, G protein, immunogenic because it is responsible for the induction of neutralizing antibodies, which support resistance. 4 non-membrane proteins, the N protein very associated with the nucleocapsid, the L protein which is a polymerase, the matrix proteins M1 and M2. There are 5 serotypes of this virus, only one of which is pathogenic. Culture is possible on lineage cells, VHK21 and Vera, but also on mouse brain. The immunogenic power is based on the appearance in cured animals of solid and lasting immunity. It is a humoral immunity based on the presence of neutralizing antibodies directed against the envelope glycoprotein. There are 5 serotypes of this virus, only one of which is pathogenic. Culture is possible on lineage cells, VHK21 and Vera, but also on mouse brain. The virus is fragile in the conditions of the external environment. It is stable at pHs between 5 and 10 and is inactivated by the phenomenon of meat maturation when the pH falls below 5. The virus is very sensitive to disinfectant chemical substances but also to lipid solvents. The pathogenic power of the 3-day fever virus is variable because although as a general rule the pathogenic power is low, which gives a benign character to this pathology, there are however strains with fairly marked pathogenicity, responsible for more serious illnesses. In dairy females and fattening animals. The 3-day fever virus belongs to the genus Ephemeravirus of the Lyssavirus group, in the Rhabdoviridae family. Due to its membership in the Lyssavirus group, the 3-day fever virus has antigens in common with the Adelaide River, Kimberley, Berrima viruses, but also with the Pouchon and Molocol, which would cause cross-reactions and problems in interpreting serological reactions. According to Nundy and Negi, a subacute infection due to the Kimberley virus induces a low production of antibodies neutralizing the 3-day fever virus, without any real power of protection. Epidemiology. 3-day fever is a pathology especially widespread in tropical and subtropical zones of Africa, Asia, and Australia, but also in certain temperate regions of Asia. It affects cattle and domestic buffalo in intensive breeding and its economic impact is not negligible. The disease has a seasonal nature, with prevalence increasing in the hot and humid season, rainy season in tropical and subtropical zones, summer and autumn in temperate zones, periods favorable to the proliferation of arthropod vectors. The sources of infection are live animals, that is to say sick animals and asymptomatic carriers of the virus, but also by arthropod vectors. Due to its fragility, low resistance to desiccation, heat and ultraviolet radiation, the virus does not persist in the external environment. The receptivity and sensitivity of individuals are influenced by intrinsic and extrinsic factors. Among the intrinsic factors, the species plays a significant role. The 3-day fever virus is primarily pathogenic for cattle and domestic buffalo. Wild ruminants, eland, buffalo, wildebeest, often develop an inapparent infection. Overweight animals and dairy females are more susceptible and succumb to severe forms of the disease. In a workforce, as shown by Momtaz et al. In Iran, the prevalence is higher among females than among males and it also increases with age. Extrinsic factors include, among others, hot and humid season, heavy rains, physical fatigue, low-lying, wet and marshy areas, floodplains and irrigation areas. In 3-day fever, direct transmission is not known, this is exclusively indirect, vector, by blood-sucking arthropods belonging to various species of mosquitoes or Culicidae. Particularly the Culicidae families with the genera Culex, Aedes, Anopheles, Culex and Alerostris or Anopheles bancrofti are notably suspected, and Ceratopogonidae with the species Culicidae brevitasis and C. imicola. 3-day fever evolves in enzootic or sporadic form in infected countries where the vectors survive all year round.
The prevalence increases with the proliferation of arthropod vectors in favorable seasons, i.e.
in the rainy season in tropical areas or in summer and autumn in temperate climate areas. The prevalence decreases again with the arrival of the unfavorable season, dry season or cold season. During epizootic outbreaks, morbidity can be high, 50 to 100%, but mortality is always low, 2 to 3%. Pathogenesis. Following penetration into the body, the 3-day fever virus is associated with neutrophils in the blood, 24 hours after infection. Endothelial cell infection and associated hypocalcemia underlie the development of clinical and lesional signs. Indeed, the inflammatory and toxemic phenomena in the blood vessels, joints and mucous membranes would be linked to a massive production of interferon in the cells infected by the virus, with the passage of plasma fibrinogen into the joints and the peritoneal and pleural cavities. And cardiac. The significant drop in blood calcium levels would be responsible for the paralytic nervous disorders observed. Clinical signs. The incubation period in natural conditions is very short, 36 to 48 hours. Under experimental conditions, it can vary from 29 hours to 10 days, but the average is 3 to 4 days. The disease is characterized by a sudden rise in temperature with an impact on the general condition. Likewise, we will observe a sudden decline in temperature, leading in 3 to 5 days to recovery, generally without after-effects. Hypothermia is generally biphasic. During the first febrile peak, the clinical signs are discrete, little or not observed. In more severely affected animals, we notice a sudden fever with a temperature reaching 40 to 41 degrees Celsius, intense depression, inaptitude, anorexia, stiff gait, salivation and throwing, inflammation of the joints, increased pulse and respiratory rate, muscle chills and edema of the subcutaneous muscles, orbits and head are also observed. The animal, sometimes in sternal then lateral recumbency, shows some reflexes, but these gradually disappear with the progression of the disease. Loss of swallowing reflex, absence of rumination, constipation and profuse salivation become evident. The total loss of reflexes, then coma leads to the death of the animal in lateral recumbency. Note that the disappearance of these clinical signs can occur spontaneously. The second febrile peak occurs 12 to 24 hours after the first. It is characterized by pulmonary involvement with polypnea, wheezing and tearing. Secondary complications may include signs of pneumonia and pulmonary emphysema, profuse shedding, stiffness of the limbs, arthritis and lameness, and lasting paresis forcing the animal into prolonged sternal recumbency. This hypothermia phase can last 2 to 4 days. Apart from hypothermia, other clinical signs may appear or persist, such as mastitis. Clinical results leading to a strong reduction in milk secretion, abortions in 5% of pregnant females and infertility in bulls. In general, animals in good physical condition, obese, good milkers, pay a heavier price for the disease than lean animals and non-lactating females. The progression can lead either to death in certain individuals following the progressive loss of reflexes, or to the cessation of swallowing and rumination, or to recovery in 5 to 6 days, in the absence of any complications. Pulmonary emphysema, locomotor ataxia, persistent stiffness of the limbs. In milkmaids, in the event of recovery, the level of milk production is always lower than that before the illness. Lesions. Cerofibrinous polycerositis of varying degrees, in the joint synovium, thoracic and peritoneal cavities, constitutes a characteristic lesion of the disease. The serosal surfaces may also present hemorrhage and edema to varying degrees. Edema fluid in the chest or abdominal cavities contains fibrin. In the joints, this periarticular inflammatory fluid has a yellow or brown and gelatinous appearance. Other lesions may also be observed, such as pulmonary edema and lymph nodes, inflammation of the parietal and visceral pleura, epicarditis, especially at the base of the heart, necrosis at certain points of the skeletal muscles, as well as, sometimes, emphysematous lesions of the lungs, mediastinum and tissue. Subcutaneous conjunctiva. Diagnosis. The diagnosis is difficult to make on the first cases occurring in a previously unaffected territory. It is not always easier in areas where the disease is well known, due to the uncharacteristic appearance and discretion of the first clinical manifestations. In the field, the diagnosis of the disease is based on epidemiological, clinical and lesional elements. In general, 3-day fever will be suspected when one is in an enzootic zone or in a season favorable to the proliferation of arthropod vectors, hot and humid season, low, humid or marshy area, delta or floodplain, in an intensive breeding of dairy or fattening cattle and of improved breed, presenting a febrile episode associated with stiffness of the limbs, with lameness affecting several animals simultaneously with a rapid progression towards recovery. The presence of serofibrinous exudates in the joints will also be a very suggestive sign of the disease. Differential diagnosis must be carried out, depending on the location, with hypothermic diseases, nervous or respiratory diseases. Among the hypothermicing diseases, let us quote, Rift Valley fever, catarrhal fever. These diseases have in common that they are due to a virus transmitted by arthropod vectors, arboviruses, that they cause hypothermia, but also that they appear especially in the hot and humid season, favorable to the proliferation of arthropod vectors. Among the diseases of nervous or respiratory expression, let us cite botulism, ehrlichiosis of ruminants, poisoning by poisonous plants, crotalaria, diplodia genera, hypocalcemia, pulmonary emphysema, and acute lung edema. In general, 3-day fever progresses benignly and recovers within 3 to 4 days, in the absence of complications. Diagnosis. Laboratory diagnosis uses direct and indirect microbiological methods, from blood samples from animals in a hypothermic phase, to detect the virus and specific antibodies. Histological research on a blood smear on a slide makes it possible to carry out blood counts, but also immunofluorescence. Numbering formula allows you to count the figured elements of the blood. In the presence of neutrophilia, percentage of neutrophils significantly greater than 30%, associated with numerous immature forms, 3-day fever can be strongly suspected. Immunofluorescence makes it possible to highlight and identify using immune serum. Virus-specific antibodies are marked using a fluorochrome, the presence of the virus or its antigens on the smear. Isolation of the virus is done by culturing blood leukocytes on lineage cells, BHK21 or Vera, or inoculating newborn mice intracerebral. The virus is identified by neutralization of the virus in culture in the presence of specific antiserum or by immunofluorescence on the cell layer. Demonstration of the viral genome can be done using conventional polymerase chain amplification coupled with reverse transcription, RT-PCR. Its sensitivity, higher than those of isolation and identification of the virus and conventional RT-PCR, also allows earlier detection of the virus. Indirect microbiological diagnosis aims to detect neutralizing antibodies using viral neutralization tests or the enzyme-linked immunosorbent assay, ELISA, treatment. There is no specific treatment. However, symptomatic and hygienic treatments can be implemented. Prophylaxis. In terms of health, the fight is based on the implementation of hygiene rules on farms to reduce the effect of contributing causes, but also on the control of arthropod vectors. The results are limited, particularly in countries where livestock farming is carried out in a pastoral manner and because vector control is not entirely satisfactory. In enzootic countries, strengthening the defense capacities of sensitive organisms compensates for the inadequacies of health prophylaxis. Medical prophylaxis is based on active immunization which seeks to make the organisms to be protected produce their own defense weapons through vaccination. In the structure of the virus, the immunizing principle is the envelope glycoprotein. The vaccines used are based on inactivated or attenuated whole viruses. Vaccines inactivated with ethylenimine and adjuvanted with aluminum hydroxide have given irregular results in the field. Attenuated virus vaccines, combined with an immunostimulant and administered twice 15 days apart, have given better results in Australia. The immunity conferred lasts 1 year and protects against severe forms of the disease, but not against infection. Recombinant vaccines, insertion of the G protein or envelope glycoprotein gene into an expression vector, poxvirus, have given promising results experimentally and are therefore vaccines of the future.